Okay, so when we talk about the endocrine system, looking at the glands, the pineal gland is responsible for secreting melatonin. That's with our sleep-wake cycle. Pituitary gland, it's secreting growth hormone and it controls the other glands. I'm going to be moving down, thinking of the thyroid gland that's in charge of the hormone that controls our metabolism. On the thyroid gland, we have four tiny glands that are like 4 grains of rice, the parathyroid gland, right? And that helps control our calcium levels as well, right? Then we're moving on down. We think of the thymus gland. The thymus gland is a part of the immune system, is more active in your pediatric patients. It shrinks as we get older. Moving down, we have the pancreas, which is a double dipper. Not only is the pancreas a part of the endocrine system because it secretes insulin and glucagon, but it's also an accessory organ for the digestive system, right? Because it helps to neutralize stomach acids. Then we move down on top of the kidneys, we have the adrenal glands, right? And the adrenal glands are responsible for, and this is how you can utilize your pectorals. Your adrenal glands are responsible for glucocorticoids, mineralocorticoids, and androgens, right? And so I know we only have a short time together, so I can't give you everything, but if there's some of these terms that you're like, oh, I don't know, I guarantee you when you crack open your med-surg book, and if you go to those notes that I showed you, they're probably going to be there. And that's a way that you could brush up your knowledge of the endocrine system. Okay, so that's kind of a way to, thinking again about the anatomy and the physiology. Now, there's certain endocrine conditions that I want to make sure that you understand. And then after I give you this, I'm going to also share some links with some videos, short videos from Kathy Parks. Because if your test is next week, these are great big systems. Her videos are 5 to 10 minutes long, and they will help you get what you really need to know. Coupled with your Hearst, excuse me, and coupled with the notes, I think you should be in good shape, okay? So let's talk about Addison's disease. So what do you all know about Addison's disease?
Um, isn't it hypo? So it's like not enough steroids.
Yes. Okay. Very good. Excellent. So, and if you are a visual person, if you remember this lady, right, the Addison's lady is what I call her. This patient has adrenocortical insufficiency. So this deficiency is the adrenal glands that are sitting on top of the kidneys. I call the adrenal glands party hats that sit on top of the kidneys, right? So if your patient doesn't have enough of this particular hormone, they'll have the bronze pigmentation. They can be depressed, hypoglycemia, postural hypotension. Their blood pressure drops from lying to sitting to standing, tachycardia, GI disturbances, fatigue, and weakness. They will have profound fatigue, excuse me, dehydration, vascular collapse because they have a decrease in their blood pressure, a decrease in their serum sodium, and an increase in potassium. So keep in mind everything that's going on with too little. And I just want to share this because this could be a test question. If your patient is taking prednisone, which is a corticosteroid, the patient has to be advised the importance of weaning off and not abruptly stop taking it because they can go into an adrenocortical insufficiency and they can end up with symptoms like they have Addison's disease, right? So that's really, really important to understand. Okay, keep in mind what the Addison lady looks like. Now we're going to look at the opposite. What happens if I have too much or if the patient has excess of this hormone that's secreted by the adrenal glands? Well, they're going to have Cushing's syndrome or Cushing's disease. And so the disease is more severe than the syndrome. So this is a classic kind of thing. They're going to have what's called a moon face or a pie face. They're going to have the opposite of what Our Lady had. She had hypoglycemia. This patient has hyperglycemia. They can have personality changes. They are increased risk for infection. They have central or truncal obesity, and they have thin extremities. They also run the risk of osteoporosis, so brittle bones. They have purple striae or stretch marks on their body. They have bruises, petechiae, that pinpoint rash. Females will cease to have a menstrual cycle, and they will grow hair in odd places, right? That's what hirsutism is. I had a teacher like that in second grade. I remember her, Mrs. Showers, and she had like all of this chest hair. And looking back now, I realize she probably had some hormonal issue going on. But anyway, random thing. Males can also have gynecomastia, so man boobs, but really breast development, right, in males. And if you remember, our um Addison lady had issues with sodium too, but she was dehydrated. Our Cushing's gentleman is the opposite. He's retaining fluid, so there's going to be edema. Okay. And then, of course, the central nervous system irritability. So, when you are studying this, looking at the notes, and you go through all the alterations in the endocrine system, you should be looking at this and saying, okay, this is what happens in this condition. This is what happens in this condition. These are the clinical cues, the things that I should look for that tell me, okay, yeah, this patient has this condition. Oh, one thing I didn't mention, this is important. Fatty deposits on the face and the back of the shoulder. Sometimes it's called a buffalo hump. Okay, so you could see that as well. So as the nurse, you should be able to paint a picture, right, of this patient. And they talk about next generation, these clinical cues. Okay, if my patient comes in and they've got this truncal obesity, they got thin extremities, they got a buffalo hump, they got striae, I'm thinking, okay, we need to do some blood work because I'm thinking this patient has corticosteroid excess. They've got Cushing's, right? Any questions?
Mm,
Okay, awesome.
no.
Um, Diabetes is a big one, and there's so much we could do with diabetes, but I think that like that's one that is like very common. So I'm not going to focus on diabetes extensively. I'm going to go to the thyroid. Okay, so we started with low for Addison. So let's talk about what if the patient has low thyroid. Okay, thyroid hormone. So why would a patient have low thyroid? Maybe their thyroid gland has a tumor, maybe their thyroid gland was removed. Excuse me. So hypothyroidism. So they don't have enough hormone secreted by the thyroid gland. This is what the patient's going to look like. So these are the clinical cues. They're going to be intolerant to cold. They'll have a receding hairline, facial and eyelid edema, this blank expression. They could have generalized edema, thick tongue, slow speech, anorexia, right? And I would say, as you are studying and you look at your notes, look at this picture, look at the description in your textbook, and you're like, oh, yeah, this is what, and this is what it looks like, because that way you can kind of mesh what you're reading and the visual, and you're like, it could help you remember it better, maybe, if that's how your brain works. So, dry skin. So, remember, the thyroid controls metabolism. If you have less of the thyroid hormone, that means the metabolism is going to slow down. So everything is slowing down here. We've got dry skin, we've got muscle aches, weakness, constipation because there's decreased peristalsis, menstrual disturbances, and whenever a patient has menstrual disturbances, that's the body's way of saying, hey, look, I can't support a developing fetus, okay? I can barely keep you alive, so I cannot support a developing fetus, okay? So late clinical manifestations of hypothyroidism, bradycardia, could be weight gain, decreased in level of consciousness, cardiac complications, right? The thick skin. So in your nursing mind, I'm already thinking, well, what are my nursing Interventions. Well, I'm thinking this patient's going to be taking Synthroid, right? Or levothyroxine, right? I can never say that medication. But, and I know that that medication needs to be taken first thing in the morning on an empty stomach for better absorption, and it could also cause insomnia, right? So these are the things that you have to think about as you're studying these conditions. Okay? Any questions on the hypothyroidism person?
When you think hypothyroidism, should you just like associate it with like the rest and digest, like
Um,
signs and symptoms,
You
or not?
can. You can, absolutely. Whenever, and that's a good thing, Sierra, whenever you have a medical condition, you should think about how it affects all of the body systems. That is an excellent way to think about it. Because when you see those select all that apply questions, those extended select all that apply, you're going to get them right because those are the things that the extended select all that apply, like 10 choices, right, are made up of. Do you know all of the body systems and how that particular condition affects the body system? So I like that. All right. So do you all know Missy Elliott?
Yes.
Okay, so Missy Elliott actually has a form of hyperthyroidism. She came out and she said, I have Graves' disease. So if you remember Missy Elliott from back in the day, and y'all are pretty young, you don't maybe don't know her from back in the day like I do, but and you look at her now or more recently, right? She has these bulging eyes, right? Because of her Graves' disease. Now she has her hyperthyroidism under control, but at one point we saw her, she's like, man, what's going on with Missy? She's looking a little different. But she had these bulging eyes, tremors, maybe diarrhea, menstrual changes again, muscle wasting, and she did lose a lot of weight. Dyspnea on exertion, right? So she would get tired, short of breath, increased systolic blood pressure, tachycardia, goiter. That's another thing that goes with the hyperthyroidism. Intolerance to heat. Remember the opposite, the hypothyroidism, they were freezing, right? So fine, straight hair. So, and again, what's going to be the cure for this? What's my nursing interventions? Well, I'm going to work with the symptoms of what the patient is experiencing, but a lot of times this could be they have to remove the thyroid or a part of the thyroid. Now, if the patient has the thyroid removed, do you know Chavasik's sign and Trousseau sign? Are you familiar with those from MedSurg 1?
They sound really familiar, but I just can't think of it right now off the top of my head.
Shavasik. I know I'm asking a lot of you guys right now. So, because this is going to be another way that you can see these clinical cues. Okay, so this is a good video. Let me share this with you. Okay. Okay. You see them tapping the cheek?
Mm-hmm.
Okay. So cheek, think Shavasics. Okay. So that is an involuntary twitch that the patient is experiencing when you tap the cheek. Notice the patient has a bandage over where his thyroid would be. So this tells me that this patient probably has had his thyroid removed, maybe partial or all of it. And remember, the thyroid, there's the parathyroid glands that are on the thyroid, kind of resting on it, right, on the posterior aspect of it. So this tells me that this patient, because it's a positive Chvosic sign, that they have hypocalcemia. They have low levels of calcium. Excuse me. So this is Chvosic sign. The next thing is going to be Trousseau sign. Again, hypocalcemia, but I have the blood pressure cuff that's being inflated and tightened. And look how the wrist and the hand is going to move. And that is a positive Trousseau sign. Again, telltale signs of hypocalcemia.
Hey, 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 man, it's
Okay?
Sumeri.
All right. So you got to definitely know those signs when it comes to the thyroid and calcium. Okay, any questions about that?
No.
Okay, fantastic. Okay, let's continue. Okay, so let's go to the pituitary gland and then we're going to go to the pancreas. All right, so let me do this. So the pituitary gland is gigantism, acromegaly. There's a picture that I want to show you that will help you. Um, the pituitary gland is responsible for growth hormone. This is the one. Okay, so in as a child is growing, right? If there is more growth hormone, right, too much growth hormone before the child hits puberty, then they end up with gigantism. They become giants. If the pituitary gland keeps producing growth hormone after puberty, then we get acromegaly. Okay, so do you all know the big Kali? He's a wrestler, Andre the Giant, who's also in The Princess Bride. Okay, let me show you. You might, Andre the Giant, y'all are young, you probably don't know
The name
him.
sounds familiar. I think it must be a picture. I
Okay, I'm
can
gonna
Google
show you a
stuff.
picture. Here he goes,
Oh
Andre the
yeah, yeah,
Giant. Okay,
yeah.
so this is like classic acromegaly. Okay, so he has his body, and I'm not a doctor, I'm not diagnosing him, but I think he's a great example because here's the telltale things what's going on with the patient that has acromegaly. They have growth hormone after puberty because after puberty, you kind of, stop growing, right? Because that's you reach your adult size. But the thing with the patient that has acromegaly, they have this ridge on their eyebrows. They have a chin that is protruding. They also have very large hands and very large feet. Okay, and that was the picture that I was showing you before. That's why this guy is like that. He's acromegaly. So you can see the chin, the ridge, the supraorbital ridge, right? And then gigantism, they grow abnormally large, but they are proportionate. So there is a teenager and gigantism guy in the UK. It's really amazing when you see him and he's standing next to his mom. It's like, oh my gosh. Let me see. Yeah, here he is. Okay, so he's my favorite example. And I think in this picture he's like 19 years old. Okay. Now, and that's his mom. So you may be thinking like, oh my goodness. Well, there's a lot of complications that goes with those conditions. Um, So let's think about for your hyperpituitary acromegaly. Some people say that Abe Lincoln had acromegaly, but it's really not necessarily proven, right? Some people say that he had other disease. I can't think of it right now because of his thin frame and all of that. But the issue with these patients with this, this growth, right? This excessive growth is that it's really hard for them, their heart, because the heart has to now pump blood all the way, right, to their brain, to their extremities. They also have visual problems. Um, excuse me. For females, that is going to be an issue as far as reproductive. So it really places a lot of stress on their internal organs. Okay. So that's going to be important. So I'm not sure, excuse me, the level of detail that you're going to go into your classroom, but at least you have the tools if you kind of have at least a general understanding a little bit of, and then you can go from there. All right. Any questions about those the difference between acromegaly and gigantism?
You said what was the acro was when their hormones start keep growing after puberty?
Yes, that is correct. That is correct. Okay. All right. And let me now go back. I want to go to pancreatitis. Okay, so pancreatitis is a big one because it's tricky in the sense that you can have a patient with acute pancreatitis and you can have chronic pancreatitis. So let's talk about the chronic pancreatitis. We know that chronic means they have this condition, it's a lifelong condition and it progresses over time, right? So my patient that has chronic pancreatitis, they're going to be eating food, and because their pancreas is not working well, this is the patient, just like your cystic fibrosis patient, that will have to sprinkle enzymes on their food, right? And so you may have reviewed that in class or maybe in your readings. And excuse me, with this pancreatitis patient, I'm going to be looking at their skin. I'm going to be looking to see if their skin is yellow, i.e. jaundice. I'm looking at the whites of their eyes, their sclera, because I'm looking for scleral icterus. These are the clinical cues. I'm going to be looking at their stool. Is their stool fatty stool, right? Frothy stool? That is called steatorrhea. Okay, so these are all the things I have to look for in my patient that has pancreatitis. I'm going to be looking at my pancreas enzymes. I'm going to also be looking at their urine, right? So this is your chronic pancreatitis patient. If your patient who has pancreatitis, maybe it's Thanksgiving and they have a bunch of fatty, greasy foods that they should not, and they forgot to take their enzymes, now they have an acute exacerbation of pancreatitis. Guess what? This patient is going to be NPO. This patient is going to be on bed rest in the acute phase because we don't want them to have an increased metabolic demand. The reason why they're NPO, can you all tell me why?
Because they
Why?
can't break down the. Oh, I don't know.
Yeah,
Let's
yes.
see, is it because they can't keep anything now, like from the vomiting and
Yeah, so it's multifold, right? But they can't keep anything down, but we don't want them to have anything because in their stomachs, because guess what? When there's something in the stomach, the pancreas gets active because the pancreas serves to neutralize that acidic combination that is in the stomach in the form of chyme, right? That milkshake that when we eat food and 2 to 6 hours, usually it's about 4 hours, all that food is churning around and it goes from the stomach to the small intestine, particularly the duodenum, right? The first part. And that's where the acid gets neutralized because the pancreas is putting the bicarb to neutralize that stomach acid milkshake that comes through, right? So if the stomach is working, the pancreas is going to start saying, hey, I need to make my enzymes. And guess what? This pancreas is sick. This pancreas needs to rest. So that's why NPO is the thing for this patient. So if you see a test question and it says the patient is an acute pancreatitis patient, they better not be sprinkling enzymes on their food because they better be NPO. So that's how they can trick you because you're like, oh, pancreatitis, I know they get enzymes. But if it's an acute exacerbation, then they don't get anything. They are NPO and they are bed rest during the critical phase, so they don't have an increased metabolic demand. Now, another clinical cue is the Cullen's sign and the Gray-Turner sign. So this is Cullen's sign and Gray-Turner. Okay, so these are bruising that you will see, okay, on your patient. All right, let me see. So the Turner sign, excuse me, is really on the flanks. The Cullen sign is around the belly button or the umbilicus, okay? So, but it's bruising, okay? And so you should be familiar with those signs, the Cullen sign and the Turner sign. Okay, so let me show you this. Okay, so this tells me that this is pancreatitis, okay? And this is the hemorrhagic patches, okay? So this is the Turner sign, okay? Um, any questions about that? Okay, so
mm-mm.
Cullen sign and Gray-Turner sign. The other thing with pancreatitis, increased risk, right? Who's at increased risk? Women that are overweight, over 40. So, what was it? It was explained to me, fat, 40, and fast food, right? Because they have a lot of greasy foods, right? And we would never call our patients fat though, but that's a way for you to remember it. But women are at greater risk, okay? And with this, I don't know if you started talking about cholelithiasis, disease of the gallbladder, and that could be incorporated in this as well, and having gallstones and that kind of thing. So that's another thing to kind of review as well when we think about the endocrine system, okay? Let me just mention to you metabolic syndrome. Okay. Well, this is a type 2 diabetes, and she is like the poster child, right? And she's here wondering if she has metabolic syndrome. Well, type 2 diabetes, we know that it's usually because of obesity, sedentary lifestyle. The patient may have polyuria, excessive urine, nocturia, urination at night, polydipsia, excessive thirst, polyphagia, excessive hunger. This patient that has diabetes, they're at risk for recurrent infections like yeast infections. Wounds are not going to heal well, right? They can have visual changes. They can actually have diabetic neuropathy or retinopathy. Actually, I'm sorry, diabetic retinopathy. The retina can become detached. They can have diabetic neuropathy, which the numbness and tingling in their fingertips and their toes, right? So that's something we have to assess. Never, ever give a patient on the NCLEX and in real life, especially diabetic, an electric blanket. Like that is a bad idea, okay? And tell me why.
Because they don't, it might be too hot to them and they don't know because they're neuropathy.
Exactly. Exactly right. Okay. So, metabolic syndrome. I'm going to show you this one graphic. And again, you can use these graphics, excuse me, to help you. Metabolic syndrome. So I call it like the deadly triangle because usually your diabetics, they have hypertension, they have high cholesterol, and that triangle is the deadly triangle. It leads to death, right? And so they have abdominal obesity, high blood sugar, high blood pressure, high cholesterol. Okay, so this is your patient that has metabolic syndrome. They're at risk for a stroke, heart attack. Okay, not a
Oh,
healthy way to go. Okay, okay. Those are the big things when we think about the endocrine system. We briefly talked about cancer, and you had, what was the other topic? Burns and fluid and electrolytes. All right, let's see
Mhm.
what we can do. Burns, burns, burns. Okay, are you familiar with the rule of nines?
Yes.
yes.
Okay, good. You're familiar with the Parkland formula.
That I
No.
need to check it. Yeah. She
Now I
mentioned
know
that's
the
what it is.
body and the percentages, but the formula we really didn't
So,
cover. Yeah,
Okay,
we didn't cover that part.
Okay, so as long as you know the rule of nines, you can review the rule of nines. But the Parkland formula, and this is a good kind of visual, I like this one. So the thing to understand, once you get the BSA, the body surface area that's burned, remember genitalia is always 1%, right? Something real quick, for your pediatric patients, you're using the Brund-Lauder pediatric chart. You're not going to use the rule of nines. And the reason why, pediatric patients, especially your infants and toddlers, their head is not in proportion to their bodies, right? Their head is much bigger, right? You see toddlers, they got this little, this bobbly head and everything because they still kind of have to grow into their bodies. So that's why we don't necessarily use the rule of nines for pediatric patients. We use, and let me show you the Lund-Browder real quick. So the Lund-Browder, I don't think that's something like you have to memorize, but I want you to know the name in case you see it, because it changes based on their age. Let's see. Yeah, I don't think you have to like go into detail, but I do think you'll have calculations for the other one. Um, and if you have class, you can also ask your instructor exactly what they want you to know about it. But the Lund-Browder, and just let me give you an example so you can see what I mean. It's their age of the child, right? you can see that, the percentage of the head changes. As they get older, it's a smaller percentage, and it more gets closer to what we do for adults. Just because again, the infant and toddler, their head in proportion to their body is larger. That's the big thing that you need to know. And so it's Lund and Browder chart for burns, and that's usually for your pediatric patients, okay? But let's go back to the Parkland formula. Okay, so this is for second and third degree burns. So this is an important calculation. I know, like in my Med-Surg 1 class for the PNs, they had to do a Parkland formula. So I can guarantee that you're probably going to have to do a Parkland formula calculation as well. And it's not that bad once you get the hang of it. So what this is determining is how much fluid I need to give to my patient in the first 24 hours. Because we know with burn patients, we're worried about a lot of things, but we're worried about dehydration, we're worried about their airway, we're worried about infection, right? So there's a lot that goes with burn patients. Later on down the road, once we get them stabilized, we're worried about body image issues and that kind of thing, right? But initially, we're just trying to keep them alive. So 4 ml is a constant, okay? Just memorize 4 mLs. So body surface area, you're going to use the rule of nines to determine how much of their body was burned with the second and third degree burns, or this partial or full thickness burns, because I think that's the terms they're using now. And then you will multiply it by their body weight in kilograms. Okay, you're going to get a large number, right? So I know when you're doing your dosage calculation, you're like, man, if I get like 1,500, that's large. But for this, you're probably going to get something like, maybe it could be 5,000, 6,000, right? Whatever number you get, when you multiply all of those values, you're going to divide it into half. So say you multiply 4 times the body surface area that's burned times the body weight, you get 6,000, right? mLs. Well, I'm going to divide 6,000 in half, and that's going to be 3,000. But in the first 8 hours after the patient has been burned, I have to replenish 3,000 mLs of fluid, and that is going to usually be lactated ringers, okay? Because I have to rehydrate the patient. That's going to be huge. And then the next 16 hours, I'm going to give that other 3,000 mLs, okay? Any questions about the Parkland formula?
Yes. So I have a question. So, because I'm not sure like how the question will be asked. Because you said for the body surface area. So say if they wanted to know, say if the patient was burned from their legs and arms. So would that be, so would my body surface area just, would it be the 18 plus 18? Like, I'm not sure like how to, like, because I see the nines for the head and the 2 arms, and then I'm guessing for the legs is it 18-inch or the 9?
Okay,
You
so
get what I'm
great.
trying to say? Because I don't want to get
Yes,
confused, like
yes,
if it's
okay,
more than one body part that's burnt.
okay, yes. So great question. All right, so let me give you this, and I'm going to put this link in the chat, and then I'm going to explain. And so take some time also to watch this video. It's about 8 minutes, and she's going to explain it to you. So here's the thing. If the patient, their right arm, the front of their arm, anterior, excuse me, portion of their arm is burned, that's going to be 9%, right? Actually, no, it's 4.5. If their entire arm is burned, right, anterior and posterior, that's going to be 9. So they could say the anterior portion of the arm, the right arm is burned. So that's 4.5%. They could say the anterior portion of the right leg is burned, so that's going to be 9%, because what this is showing you is that for each arm is 9, right? Front and back, posterior and anterior. For one whole leg, that's 18, which 9 plus 9 is 18. And so that's going to be divided into anterior excuse me, and posterior. So if the front of the right leg was burned, that's going to be 9%. If the entire right leg was burned, that's 18%. Combined with the front of the arm, that's adding another 9 to it. Right. So that's how you would determine. If their genitalia was burned, you add 1%. If their entire torso was burned in the anterior, that's going to be 18%. If their back was burned, that's another 18%. If their whole head was burned, like their face and then the back of their head, then that's 9%. If it was just their face, that's 4.5%. Okay, does that make sense a little bit better now?
Yes, it does.
Okay, awesome. And Sarah is going to go through this with you and she's going to calculate it. But again, you've got the idea. Once you get the BSA, then you multiply 4 milliliters of that fluid, which is usually lactated ringers, times their body weight. Remember, we're always working in kilograms, okay? And let me give you this one because she also has a rule of nines video that actually is really good too. So, because I know you have a lot with burns. Okay. Let's see. I don't see anybody coming for MedSurg 1, so I'm gonna keep going. Because I was supposed to be doing MedSurg 1, but we're gonna keep going. Let's talk about the integumentary system since we're on burns right now. And integumentary system, I'm gonna just rely on my visuals real quick. Here we go. So let's see, what do I want to say about the skin? So there's a lot with the skin, but let's just talk about the layers of the skin first. Again, always starting with the anatomy and the physiology. Remember, the top layer of the skin is the epidermis. That is what we see. That is where hair is, coming out of. That's where our melanocytes are. This epidermis is dead. It is dead cells, and they're sloughing off. And these cells are keratinized, right? That's what makes us waterproof. The skin itself is the first line of defense against injury and infection, right? So whenever there is an invasive procedure, I'm always worried about hemorrhage and infection. Hemorrhage is going to kill the patient fastest. Infection, I'm going to know because there's going to be warmth, redness. The patient may have a fever. There could be exudate that's purulent or malodoriferous, right? So these are all things to think about. When I think about the skin, I'm also thinking about my geriatric patient. This subcutaneous tissue that you see is the third layer. Sometimes called the hypodermis, that is lost in our geriatric patients, thereby making their skin thinner. Also, you see that second layer, the dermis, that's where your elastin, your collagen, your sweat glands, your nerve endings, your blood vessels are all hanging out there. But in my geriatric patient, they have a loss of, again, elastin, collagen, subcutaneous, that makes their skin very thin, easy for tearing, easy for bruising, that makes them cold a lot of the time, right? So these are all things that have to do with the skin. My diabetic patient, their skin is usually really dry, right? And again, we want to maintain skin integrity, okay? So this picture shows you the depths of burns, right? Superficial, partial thickness, and then full thickness. That's usually used to be called first, second, and third degree burns. The thing that you have to understand about how each of these burns presents itself. So when my patient has a full thickness burn, they're not going to feel any pain because they burn right through those nerve endings that are in the dermis. Everything's all burnt up. They're burned pretty much down to the bone. Okay, so there's not going to be any pain. But the second degree or partial thickness burns are extremely, excruciatingly painful because of all of those free nerve endings, those pain receptors that are inside of the dermis, okay? So as a nurse, you should be thinking, man, so she told me I should be scared of infection when it comes to my burn patients, dehydration, and now I got to manage their pain, right? So yes, that is it. And I'm going to tell you, The smells from burns are not good, and it takes a special nurse, I think, to deal with the burn units. It's really heartbreaking because that burn, right? If it's a second degree or third degree or full thickness burn, if they have any good skin left, they will possibly do a skin graft. And are you all familiar with skin grafts?
I
Yes,
know we briefly went over it. Isn't it I think it's called
like
angio, comes from yourself or something?
the
Oh,
autograph, and then
Oh,
you
the
have the
autograph? Yeah.
isograph, yeah, and then the
Comes from somebody
xenograph.
else.
yes, so you should look at that. There should be a table in your book that talks about the different kinds of grafts. The allograft, the autograft, the xenograft, right? So it could be from the own person, it could be from an animal, could be from a donor, it could be synthetic, but you need to be familiar with those different kinds of grafts. The thing is, when a patient donates to themselves, like if their arm, like this picture, the arm is burned and they go to the thigh and they take a chunk of skin from there. Now you have two wounds that you got to take care of because that skin graft site is now missing skin. So we have to make sure that that doesn't get infected. Okay, so it's really a lot. And when we think about skin, think about nutrition, think about protein, think about zinc, think about vitamin A, vitamin C, vitamin E. In your textbook, it's going to tell you each of those has a specific role in healing the skin. The big thing, of course, is protein, but all of those other minerals and vitamins help with blood vessels and help regenerate cells and all of that. So that's going to be important for that patient to have a diet rich in those things in order for them to heal. Okay. All right, so that's your burns. And please do not put butter on burns. Do not put lard on burns. Do not put ice on burns. It should be cool water, right? That's like, I'm sure you're going to get a question about that. Okay. All right, let's just because this is under integumentary, Kawasaki syndrome. I don't really know if this falls under skin though. Um, have y'all even talked about this at all in class? I don't think this falls under skin.
I don't
No,
know. I don't think
I
so.
don't think.
It
No,
No,
doesn't.
yeah.
no, but this is still good to know. I don't think it falls under skin. I'm not sure why, but I guess, excuse me, because of the strawberry tongue. So with Kawasaki, this is usually in children. The deal with this is they have red soles. They have these rash or this redness on the palms of their soles and the palms and their feet. And it can affect the heart as well. Okay, so maybe that's why they had it um under the skin. Okay, Lyme disease, that's a good one to know. It's getting to be summertime. The big thing with Lyme disease is that tick, right? You could get this on a question. The tick. The tick must be removed, right, with a tweezer. They don't want to, and the thing is, they should really take that tick and put it in a plastic bag and take it with them to the emergency room to make sure they got all the parts of it because they can have parts of the tick still burrowed under the skin. They can also test that tick for any disease. That's a good thing to do. Um, and a bullseye rash is going to be that telltale sign, okay, of Lyme disease, okay? Bullseye rash, okay? And all they have to do, if the patient is infected by, is bitten by an infected tick, antibiotics, if taken within the first 2 weeks, can help this patient. But if they don't get appropriate treatment, then they have Lyme disease. And sometimes patients have the symptoms of Lyme disease for the rest of their life. Okay, so it's pretty serious. Okay, that's your Lyme disease. Okay, let's now go to the next one, which is okay. Let's see. Okay, melanoma. You should definitely know the different kinds of cancer. Let me try to find an image that I'm gonna show you that you need to know. Okay, let me show you an image. Just give me 1 second. Okay. So this is an example, and I'm pretty sure they have an image in your book. Okay, so these different types of cancer you should be familiar with. And I'm going to pause for a second because I know you might take a screenshot or Google it or whatever you need to do. Okay, so I'm not going to go in detail over all of these, but you should, because these are fair questions for MedSurg 2 on the different kinds of cancer. And you could have an exam. I saw an exam tonight and they had like pictures. So you could have a pitch, and it wasn't for MedSurg particularly, but they're showing pictures now, hot spots, questions can have, okay, this is what it looks like. What kind of cancer is this kind of question, right? The big one, if you're like, man, I can't remember this, you better remember melanoma, right? The deadliest form of skin cancer. And what we're thinking with this is, and if you remember from health assessment, irregular borders, uneven coloration, right? But again, it's the deadliest form of cancer, okay? Any questions on these types of skin cancer?
No.
Okay. The other thing, because I was reading when you told me the topics, I want you to make sure that you know about the staging of cancer. Okay.
Mhm.
The
Yeah.
staging of cancer, the TNM, are you familiar with that? The staging of
No.
cancer? Okay.
No.
Um, so let me get a good pictorial for that. So the TNM, Tango November Mike. So here's an example. So the lower the number, right, the less serious it is. The higher the number, the more serious it is. The T in the TNM cancer staging, the T stands for the size of the tumor, okay? The size of the tumor. This, and I don't think you necessarily have to memorize like the different sizes, but just know that T1 is small, and T4 is larger, okay? And this particular pictorial that I've just found is about the lungs, right? N is if it has spread or metastasized to lymph nodes. So if it's N0, that's good because that means no lymph nodes are involved. N1, N2, and 3 is increasingly more serious. And 3 means, man, there's a whole bunch of lymph nodes that are involved, okay? And again, this example is for the lungs, but we can have the same that's with, breast cancer, kidney cancer, any kind of cancer. And then metastasis has it spread from the initial organ where it started to an organ more distant. So in this case, it's lung cancer. Has it spread to the kidneys? Yes, then it's M1. Okay, so T and M is how we stage cancer. So the diagnosis is the medical condition. The prognosis is how good the doctors think the outcome's going to be, right? So the prognosis is poor, doesn't look good for the patient. Palliative care, hospice, right? When we think hospice, 6 months or less to live, and we want to manage their pain. That's something too with cancer. I can't emphasize enough how important it is to treat their pain because that's an extremely painful condition. All right, so the only thing that we did not talk about briefly is fluid and electrolytes. I did send one of you the link for the fluid and electrolyte video I have. It's about 40 minutes long.
Is that the one? I think it's like on YouTube on your channel.
Yes, that is correct.
Okay.
That's going to give you really good information about fluid and electrolytes. But what I want you to know, there's a lot of things I want you to know. Let me see if there's a quick picture that I could show you. When we think about fluid and electrolytes, Yeah, so this is the one that I want to focus on. I really want you to know the difference and how a patient would present if they have metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. I'm going to use these pictorials to kind of help us through. And I don't know, are you going to have ABGs on your test?
I believe so.
Yes.
Okay, so I'm also going to share with you then, let me do that now before I forget. I really love this Nurse Labs ABG tic-tac-toe. Are you familiar with it?
So I remember in foundations, Miss Smith was trying to show us tic-tac-toe, but it really confused me. So I just went with the way Miss Hall taught us. It made it a lot easier for me.
Okay, so you're a Rome kind of person. You like Rome better?
Yeah.
Okay, I don't love Rome, I'm going to tell you the truth. So, but
Mhm.
you can look at it, and Nurse Sarah actually has really good ABG tic-tac-toe. So, but if you learned it one way, stick with the way that you know. I don't want to confuse you, but I put the link in the chat to the ABGs by Nurse Lab, and let me just bring that to the front in case somebody's watching this video. So ABGs, it talks about what each of the things are, and the ranges, you should definitely memorize the ranges when we talk about ABGs. And hold on, okay. And then it kind of takes you step by step. And I really love this scale, but this is not, if you're a Rome person, don't look at it, it might confuse you. But this scale I love because anything that goes to the left is going to be acidosis. Any value that's to the right is alkalosis. And the 45 to 35 is flipped, so you don't have to worry about the equal opposite thing with Rome. So if the patient has a PaCO2 of 46, I know it's respiratory acidosis because PaCO2, I think lungs. Bicarb, metabolic, I think kidneys. If the patient has a bicarb of 21, it's to the left of 22, I think of Beyonce, and I think, okay, metabolic acidosis, so to the left. All right. So this tic-tac-toe grid, basically what you have to do when you get your values, you put them under each of the ones. So if your values, and I'll just show you this real quick and then I'll go back to what I was saying. If your value is acidic, I'm going to put pH. And my pH value is acidic in the problem that they give. If my PaCO2 is acidic, I'm going to put PaCO2 here. Okay. Now my bicarb, if it's normal, I'm going to put HCO3 here. But if it was not normal, if it was alkalotic, then I will put it here. Okay. And so the difference between this is I know right now that it's acidosis, and because of the PaCO2 is acidosis, it's respiratory acidosis. Okay. Does that make sense or is that confusing?
Yes. I just get confused with the partial and fully compensated.
Okay.
Mm.
So that's the next step to this. All right. So if the HCO3 was in the normal category, it would be uncompensated. So I think of it as this. The bicarb says, hey, I see you pH, I see you PaCO2. You guys are full of acid over there, but I'm going to mind my business and I'm going to be normal. So it sucks to be you, but here we are. And so we're uncompensated. But if HCO3 says, oh man, I see you pH, I see you PaCO2, you guys are so full of acid, I'm going to leave my normal condition and I'm going to go to alkalosis to try to compensate. So now you're partially compensated because this HCO3 is not in a normal range. Okay. So
Mhm.
that's the gist of it. And it could be vice versa, right? It can be switched around, or it could even be alkalosis. But if you go onto this website, do the problems, and you listen to Nurse Sarah, I think you're going to get a really good understanding of it. Okay. All right, but now the other piece, because doing the actual calculation is one part, but the other piece is when they give you those clinical cues, right? Because NGN is all about the clinical cues. When we think metabolic, think kidneys, right? So what does a patient in metabolic acidosis look like? Well, here they are. They've got too much acid and too little bicarb. This is a patient that could have their NG tube to, no, sorry, not NG tube to suction, that's alkalosis, sorry. This metabolic acidosis, they have too much acid. Excuse me. So this patient could have nausea, vomiting, warm, flushed skin, hyperkalemia, decreased muscle tone, reflexes, Kussmaul respirations. Okay, if you're not sure of what Kussmaul respirations are, look it up on YouTube and see a video. And when you see it, you're going to be like, oh man, you're going to definitely remember what those Kussmaul respirations look like. Okay. Now, metabolic acidosis, this is your DKA patient, right? So that's going to be your DKA patient. And so all the things that go with DKA, because now that I know, okay, this is metabolic acid, this is DKA, what's important? What's my nursing considerations? How do I treat a patient with DKA? Well, I'm thinking they have to be rehydrated. I'm thinking insulin drip. I'm thinking I have to monitor their potassium, right? And you know that because they already have hyperkalemia. And you know, if the potassium is too high or too low, I better monitor their hearts, right? So you got to know that, right? So these are the things, the clinical cues that you should look out for in your patients in these test questions, because that could easily be an unfolding case study. Okay, let me go to now the opposite. Okay, I like to study things in opposite because it kind of helps you. Sometimes if your brain doesn't work that way, it might be confusing. It just depends. So here's metabolic alkalosis. Well, they're basic. This is a patient that has lost their acid. This is the patient that has the NG tube to suction. They have been vomiting for a long time. And remember, I said before that the stomach is a bag of acid, right? The pH is 1 to 4. So if your patient's been vomiting, they're losing all of their acid. If they've got an NG tube to suction, they're losing all of their acid, okay? So this patient will present with confusion, again, dysrhythmia, tachycardia because they have decreased potassium now, right? Anxiety, seizures, tremors, decreased serum calcium. Remember, hypocalcemia, Chavasik sign, Trousseau sign, right? Tingling. I've seen a lot of questions with tingling of the fingers and toes and numbness and tingling of the lips, right? So you should kind of remember that metabolic alkalosis. Okay. Any questions about the metabolic piece? All right, let's go to the respiratory piece then. Okay. All right, so the respiratory acidosis. So respiratory, we're thinking lungs, right? I'm thinking PaCO2. Why would a patient have respiratory acidosis? Well, I know that carbon dioxide is going to make my patient acidic, right? So this patient is retaining carbon dioxide. What kind of patient retains carbon dioxide? What medical diagnosis?
Is COPD?
Yes, COPD. Now you got to think about, excuse me, especially your emphysema patient. They have hyperinflated lungs. They have a flattened diaphragm. They have that pursed lip breathing, and that's what this patient is trying to do, right? They can't get rid of the acid. So they're retaining, excuse me, CO2. So this patient has hypoventilation. They have hypoxia. They have a decreased blood pressure, rapid shallow respirations because they're trying to blow off that carbon dioxide. Hyperkalemia, again, we think potassium. They've got some heart issues. I'm going to monitor their heart with telemetry, dizziness, drowsiness, disorientation, muscle weakness, right? So this is usually like your COPD patient. It could be your patient in acute respiratory distress, pulmonary embolism, pneumonia, right? Any patient that has some kind of obstruction in their airway. They can't get rid of the acid, the carbon dioxide. Okay. Any questions about any of these conditions?
No.
No. All right, well, let's look at the opposite, respiratory alkalosis. Now, this patient is getting rid of too much carbon dioxide. This is your patient that's having a panic attack. This is your patient that's hyperventilating. I have no idea now if in new movies they're putting, if somebody's hyperventilating, they say, hey, breathe into this brown paper bag, right? I don't know if they're still doing that, but like back in the day, they would do that. You're hyperventilating, breathe into this brown paper bag because you need to breathe back in your own carbon dioxide because you're losing too much of it and you're becoming alkalotic. Okay. So this patient will have hypokalemia. And look, this patient is going to have numbness, excuse me, and tingling of the extremities. We saw that as well, right, in our other metabolic condition, right? Metabolic alkalosis. Hyperreflexing, muscle cramping, seizures, increased anxiety. The causes, again, hyperventilation, anxiety, pulmonary embolism, fear, mechanical ventilation. So this is important for you to kind of know these cues because they can give you a patient, paint a picture and say, okay, what condition does the patient have? Is it respiratory alkalosis, respiratory acidosis, metabolic alkalosis, or metabolic acidosis? So you got to be able to understand how the patient is going to present. And you also need to think, well, what am I going to do as the nurse? Am I going to administer oxygen? Elevate the head of the bed? What are my nursing actions? What is my patient teaching going to be? What medications should I give? Okay, I'm going to stop sharing. Just 1 second, actually. Okay, fluid deficit. Are you all are good with fluid volume deficit and hypervolemia if a patient has too much?
Yes.
Too much, too little? Okay, great. The other thing is you got to know the lab values that go with that. Okay, I'm going to stop sharing my screen. And I just want to check in with you, and I'm going to go to Markia first. We've talked about a lot of things. There's kind of like 6 chapters, I think, out of your textbook. We touched on little bits of it, so I know it's a lot. But what questions do you have? What is something that's not clear?
I really can't say right now. I feel like you did touch up on everything that we did learn, and I feel like you did give more information that kind of stay like I definitely love like the picmonic things that you have. That is definitely a plus, so I would definitely look at that throughout the week. That would help me for the test. So I guess like as the days come past, I would just like you said do the evolve and do the key points
Mm-hmm.
and also look at the picmonics. That's pretty much it. I can't say like I have like something that's still stuck that I'm not unsure of right now. I feel like you definitely brushed up on everything of the 6 chapters, which I like.
Okay, awesome. Okay, I'm gonna put in the chat my cell phone number. So like if you're studying, you're like, oh man, I've got a real quick question. Just shoot me a text. Okay. All right. Sierra, I'm gonna touch base with you. What do you think? What helped, what didn't? What do you have that's not clear?
I like the pictures. I don't think anything's not clear anymore. It was a good review. I really liked it. I really enjoyed it. I think it was very helpful. I'm a visual learner, so I need pictures and like I need to also like I read and during class and then at home, but like I need to read, I need to see it, and I need to like say it out loud. So it's like this really helped like a lot.
Okay,
I'm
awesome.
glad I have access now to those pictures because I remember when we were in clinical and we were talking about ABGs for geriatrics, Miss Harris printed out a lot of those pictures for us to
Mm-hmm.
help us during clinical, and they were really helpful.
Okay, awesome. Sounds excellent. Okay, so I will let me stop recording.